The chronic pyelonephritis. The old definition. This is an infectious, non-specialized inflammatory process of the calical-pelvical system and tubulus of the kidneys with subsequent damage to the glomeruli and vessels of the kidneys. The etiological factors are Escherichia coli, most common up to the 80%, Proteus mirabilis from the 14 up to the 16%, Klebsiella pneumonia from the 12 up to the 15%, Staphylococci and Enterococci, Pseudomonas aeruginosa, and number of the intracellular parasites including Mycoplasma pneumonia, Chlamydia trachomatis, Ureaplasma urealyticum, and Candida albicans are also can be in the etiological factors. In most cases, these are commensal microorganisms that can be in the interstitial tissue of the kidney for a long time in inactive state, in the form of L forms and so-called bacterial films like protoplasts, microbial associations that are immune to antibiotics, which are capable of with a decrease in the protective immune forces of the body go to the initial state and cause an exacerbation of the disease. The chronic pyelonephritis new definition. There is a genetically determined immune infectious mediated ascending non-specific focal inflammation of the predominantly tubular interstitial tissue in the combination with the damage to the urinary tract. It is irreversible self-progressive immune-mediated infectious disease. It is based on genetically determined violation of local immunity, leading to an increase in the sensitivity to the certain pathogens, violation of the urodynamics, and the development of the inflammation that captures all structures of the renal tissue and the mucous membrane of the urinary tract. Pathogenesis. The genetic defect. A greater number of receptors of mucous membrane of the urinary tract to the microorganism commensal, leading to adhesion of the larger number of microorganisms on the mucosa. The association of chronic pyelonephritis with the certain HLA antigens. Secondary immunodeficiency. Viral diseases, stress, hypothermia, hypertension, hyperinsulation, medication, and other for the implementation of the genetic factor. Urodynamic disorders like pyelorenal reflux and increased pressure in the urinary system. The development of the immune complexes in places of adhesion of the microorganism on the mucous membrane of the urinary tract with their entry into the urine and throwing with reflux them into the papillary zone of the kidney, which has a special hemodynamics that contributes to their fixation and the development of the inflammatory reaction that spreads to the renal tissue, including the glomeruli. The complex interaction of cellular reactions and intercellular matrix like proliferation, exudation, alteration, numerous intracellular reactions, autocrine, paracrine, endocrine, including along with antigen-specific reaction, the participation of the vasoactive peptides, anaphylotoxins, a complex of membrane attack, complement, interleukins, colony-stimulating growth factors, and other, and also exodus, the development of the interstitial fibrosis with glomerular death and progression of the chronic kidney disease. Epidemiology. Women make up 67% of pyelonephritis patients. 70% of patients are persons from the 20 to the 40 years. 10% of patients become ill before age of 10 years. In the future, pyelonephritis occurs with the same frequency in all age groups. The clinical picture. Main syndromes: urinary pollakiuric intoxication, hypertensive, and anemic. Urinary syndrome. Leukocyturia is an indicator of the activity and acuity of the process. Hematuria, more often microhematuria, up to the 3 to the 8 red blood cells in the field of view. Proteinuria is often minimal, up to 1 gram, rarely massive proteinuria as a manifestation of the nephrotic syndrome. Cylindruria is much less common than with glomerulonephritis. Pollakiuric syndrome. Thirst, due to the violation of the process of urine concentration due to the inflammatory edema or with the development of the nephrosclerosis. Decrease in the relative density of urine, polyuria, and electrolyte losses. Intoxication syndrome. Malaise, fatigue. Subfebrile temperature, changes in the leukocyte formula, toxic granularity of neutrophils, and acceleration of ESR. Hypertensive syndrome, not specific to chronic pyelonephritis at the onset of the disease. It is the marker of the development of nephrosclerosis. Anemic syndrome, associated with the impaired kidney production of erythropoietin, characteristic to the late stages of the disease. Clinical forms: hypertensive, nephrotic, septic, hematuric, anemic, latent, and recurrent. Clinical forms: latent form characterized by scantily clinical symptoms. The manifestations are unmotivated weakness, cognition, sometimes noctury, non-intense pain in the lumbar region, which is often explained by osteochondrosis of the lumbar spine. The recurrent form, characterized by alternating periods of the exacerbations and remissions. Manifestations are: in the period of the exacerbation, the clinical symptoms are distinct. There are previously described clinical syndromes. Severe exacerbation may be complicated by the papillary necrosis. In the period of exacerbation, the severity of the chronic renal failure is aggravated. After relief of exacerbation, the phase of remission occurs. The clinical and laboratory manifestations of the disease gradually subside. Clinical forms: hypertensive form. The manifestations are arterial hypertension syndrome comes to the fore, urinary syndrome is expressed slightly and sometimes inconsistently. If the patient has arterial hypertension, it is always necessary to exclude chronic pyelonephritis as its cause. Anemic form and manifestations are: anemia dominates due to the violation of the erythropoietin production and the influence of the intoxication. More often, anemia is observed with the development of the chronic renal failure. The changes in the urine can be minor and inconstant. The clinical forms: septic form develops during the period of the severe exacerbation of the chronic pyelonephritis. The manifestations are: high body temperature, stunning chills, severe intoxication, hyperleukocytosis, often bacteremia. Hematuric form, it is rare form. The manifestations are: macrohematuria. It is necessary to thoroughly examine the patients and exclude all possible causes of the hematuria: tuberculosis and malignant tumor of the kidney, bladder, kidney and bladder, urolithiasis, hemorrhagic diathesis, severe nephroptosis, immunoglobulin A nephropathy, and myeloma kidney. Diagnostics: general urine analysis, general blood test, urine analysis according to the Nechepurenko and Zimnitsky, bacteriological examination of urine, more than 100,000 bacteria in 1 milliliter, including determination in the urine of the bacteria coated with the antibodies, study of HLA system antigens, X-ray examination, slowing down the excretion of the contrast agent and on the site of the lesion, local spasms of the calico-pelvic system, atony of the ureters, deformation of the calico-pelvic system. Thermography: temperature increase in the lumbosacral region with an active process. radionuclide renography, asymmetry of drug excretion, radionuclide scanning, dynamic scintigraphy of the kidneys, detection of the large and small scale filling defects, echography of the kidneys, kidney biopsy, if necessary, differential diagnosis with the glomerulonephritis, amyloidosis of the kidneys. Differential diagnosis with chronic glomerulonephritis, amyloidosis of the kidneys, kidney tuberculosis, necrotic papillitis, interstitial jade, kidney hypoplasia, polycystic kidney disease, and asymptomatic bacteriuria. Treatment: exacerbation of the disease in an indication for hospitalization. Diet: a strict diet is not required. With the development of the arterial hypertension, the salt restriction up to the 3-4 grams. In the absence of the urinary retention, at least 1.2 and 2 liters of the fluid per day is recommended. The antibiotic therapy. Treatment should not be aimed at sterilization of the urinary tract. It's a useless task. Antibacterial drugs are used in the shortest possible course. For example, fluoroquinolones, cephalosporins of the second and third edition, protected aminopenicillins, clotrimazole, preparations of nalidixic acid, and nitroxaline preparations. Treatment: the plant uroseptics, bearberry, St. John's wort, sage, chamomile, rose hips, lingonberry, knotweed, birch boots, juniper berries. You can use paste also phytolizine. Drugs that improve microcirculation in the renal tissue, Trental, Curantil. Plant immunomodulators like ginseng and Eleuterocoque. Chronic kidney disease. This is the presence of the kidney damage or a decrease in the level of the kidney function for 3 months or more, regardless of the diagnosis, as well as all patients after kidney transplantation, regardless of the level of glomerular filtration rate, the presence or absence of markers of the renal damage. So, risk factors of the chronic kidney disease. Non-modifiable: older age, male, initially low number of the nephrons, racial and ethnic characteristics, hereditary factors including family history of the chronic kidney disease. The modifiable: diabetes, arterial hypertension, autoimmune diseases, systemic infection, infectious encroachments of the urinary tract, obstruction of the lower urinary tract, drug toxicity, high protein intake, dyslipidemia, smoking, obesity, metabolic syndrome, hypergomocysteinemia, and pregnancy. The chronic kidney disease diagnostic algorithm. Markers of the renal damage: microalbuminuria, explicit proteinuria. Changes in the sediment of the general urine analysis. Data of imaging research methods including biopsy. If present, to establish nosology and chronic kidney disease and determine the stage of the chronic disease. If no glomerular filtration rate less than 60 ml per minute is chronic kidney disease, and determine its stage, and more than 60 ml per minute, risk factor analysis. Stages of the chronic kidney disease. There are 5 stages. First, with the renal damage with normal or high GFR. Second, with the renal damage with the minor GFR. 3, moderate decreasing of the GFR. 4, pronounced decreasing of the GFR. And 5, renal failure. Thank you very much for your attention.